My name is Dr. Mukono. I'm going to be going over inhalers, give everybody an opportunity who is prescribed previously inhalers, currently, or thinking about they need an inhaler. I want to make sure we go over some of the basics. Some of you might be my own patients, or you may be a visitor or curious caretaker, parent, whoever you may be. I just want to make sure that we understand that I am not your provider on here, even if you're established in my office. I just want to make sure I give you a resource of where you can make everything just fit in together properly. It could be your starting point, it could be your revisiting point, it could be anything, but it is not a visit. So for that opportunity, we obviously have lots of avenues for you to get a provider one-on-one, including me, and we could go over those things on a one-on-one basis where it actually can apply as your care, right? For right now, it's just mainly for your resources and educational purposes only. So again, my name is Dr. Mukono, and I love to teach the inhalers. I am a pulmonologist. I teach them in my office. I teach them here. I teach them on TikTok. I actually also teach them on Amazon. So if you've seen me in any of those avenues, hi, and nice to meet you. I would love that we have it where you could ask a question during this live, or you can also ask this question during your own special time at any particular convenient schedule that you have. I do not want you to feel like you need to ask me a question on here, but you could ask your provider as well. I'm going to be going over a series of inhalers. I want to make sure that we grade these inhalers according to your understanding. And I just want to make sure you understand that as of right now, the inhalers that I know, they require a schedule. The maintenance inhalers should be differentiated from the rescue inhalers. When I say maintenance, what do I mean? I mean that is the inhaler that your prescriber has actually put in on their prescription that you need to take it once or twice a day. So that twice a day part is not for you to edit to make it once a day. It is really not meant for you to edit and make it when you remember. As soon as you do that, you're really going to have a problem, because those inhalers won't work if you don't follow the schedule that they were prescribed. With a little disclaimer, I just want to let you know that if you were prescribed one of these, this is why sometimes you get confused, is that your inhaler was prescribed and you were told, take this one as needed. And all of a sudden, you now take that instruction and you paste it on one of these. It's the biggest danger point that you can have. It actually could cost you more hospitalizations. It will cost you more visits to me, and someone like me, pulmonologist, out there would enjoy you, yeah, and you would not like that, because you would think that they're somehow they're making a mistake. They probably prescribed it right, and the way you figure it out is you go and find out, do I have a maintenance inhaler? And yes, the confusing fact is that maintenance inhalers can look very similar to your rescue inhalers like these. This actually is a special rescue inhaler because it looks like a maintenance, it behaves like a maintenance sometimes for some people, maybe with really, really, really mild disease, but this is still under the rescue plan, right? But we have inhalers like this that look like this, but this one is a maintenance inhaler while this one is a rescue inhaler. And I just want you to know that if you're getting confused, many people are. And what they do is they start mixing and matching and swapping things, and they get really screwed up by that. And then they get really sick, and then they're never better. And then it kind of progresses their disease later on. It's difficult to deal with it at the end. We still deal with it, but it's more difficult. So you start off and you kind of wrench up into this disaster later on. And I'm not trying to scare you. I'm trying to tell you, when it's controllable, your situation actually looks like this. The asthma, and maybe even the COPD, when you're mildly smoking, you're like this. And then eventually you get really, 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 really bad, and you scar over and you become like this. And there's something called the elasticity of that lung it's so stiff over here. It's hard to correct years later after abuse, bronchitis, pneumonia, really terrible bugs that stick onto your lung and never want to let you go because you have made them completely comfortable in your lung with an untreated lung. And I'm just trying to tell you that when you're first diagnosed, your lungs look very clear. They are very wide open, they breathe fine, and you feel fine. And you don't see the point of us telling you you have asthma, because what happens with asthma is that your lungs start doing something like this. And they, instead of going in and out, they kind of just act crazy. And they're tight, squeezy, irritable, panicky, and just completely unruly. Like they just run their own show. They're breathing against you. They're not working with you. That is usually the clue that you have an asthma or you have COPD and these other things, you know, like they run across with each other and they kind of merge in together and you start getting different diagnoses. And as soon as you get a different diagnosis, you feel better about it or worse about it because it's called something different. As far as I'm concerned, if you're an asthmatic, you can get bronchitis. It's also the same as a flare of your asthma. It's the same thing, asthma exacerbation. I'm sorry, it's the same thing. We just call it different. And I don't know why we do that, but yes. If we know you have asthma, we're gonna tell you it's an asthma flare-up. If we don't know you have asthma, we're gonna call it bronchitis. So you're gonna run away with that. And then if we find a bug, we may tag Pseudomonas, we may tag staph, we may tag COVID and co. We can say anything because that is now what lands on top of that flare, right? And then we can call it pneumonia or not. And then some people will say, well, I didn't have pneumonia yesterday and today I have pneumonia. Well, you let things fester for too long and they turned into a pneumonia. Why? Because the lung can't clear that phlegm that you've accumulated in that area of that lung. And now we see a picture change. And so we're gonna call it a pneumonia. And now you're hospitalized and you wanna fire all your doctors. And that's just how it feels. Because someone finally diagnosed you with pneumonia now because they did an x-ray. All the other doctors probably didn't do an x-ray. And to be honest with you, they probably, in the beginning, didn't make a mistake because if you have bronchitis or pneumonia or asthma flare-up or COPD, we usually give you a little antibiotic and steroid. So therefore, we would take care of both of those things. And the x-ray just tells us just how bad did these things get, right? If it's just inflaming your lungs, like in the airway, it may not give you a pneumonia, but once it starts breaking down that tissue and inflaming it, you can, oops, sorry. Sorry, 1 second. I'm sorry. So you can actually, excuse me, you can actually feel like it's inflamed. Your lungs get inflamed and you feel like, okay, I have a bronchitis. You use your inhaler. It doesn't help because at that point, your lungs are way into the midst of a flare that you can't settle them down. So what do we do then? The lung then is really in this vicious cycle. We call those flares or exacerbation. What about an attack when your lungs just completely spasm down and they do not take in air? Now it's dangerous. You cannot even do half of the things I'm asking you to do, which is hold your breath, synchronize that breathing, and take in your inhaler. You're in an asthma attack. That's dangerous, right? Then we are gonna put you in the ICU for that because we feel like your lungs are in danger of shutting down completely. So that's the extreme of everything. Respiratory failure, asthma attack, that's the extreme of everything. And I wanna let you know that we are discussing all what I discuss here is hopefully getting you before the attack, before the flare, before the exacerbation. What I'm saying to you is that when your lungs are actually doing well, they're gonna say, well, maybe a little wheeze, maybe a little flare, maybe a little tightness, maybe a little squeak, maybe a little feeling like your lungs have a little chest pain and extreme chest pain. Go see the cardiologist, go do what you need to do. I'm only telling you about asthma and COPD. Your lungs are not working with you, they're not cooperating with you. We are going to say, well, you have asthma. If you don't have an infection, or we don't think it's really bad, we may not give you anything more than an inhaler. Sometimes a nebulizer to help you calm things down. This is the milder spectrum of everything. The severe spectrum gets everything I'm talking about later, after that severe episode has been brought back down to earth and you're back to your baseline. And then we release you from the hospital, and we still want you to come back right here where I am talking to you about making sure you use your inhaler as you're supposed to. And that's why everything needs a head start. It's like it's a race. If you're going to win or the asthma attack is going to win. Asthma is working, and actually COPD is doing the same thing on a daily basis. So imagine a problem that's happening daily and you decide you're going to treat it monthly. It's not going to work. You really have to be consistent with your plan. If you are prescribed just a rescue and your issue has become a daily adventure or more consistent, your asthma is constantly after you, then just having a rescue inhaler will not work. You need to go and talk to your provider about what else could be going on, or is it that your lungs got worse, or do you have a pneumonia coming in, or a bronchitis, or something has set off your asthma and your COPD or whatever. I'm using them interchangeably because we do overlap pretty nicely. One from smoking, of course, vaping, and using everything toxic to your lung, even including cooking with coal and everything that gives you COPD is not just cigarettes, it's more than that. But we always talk about cigarettes. But then we're also talking, some people have both asthma, COPD, and some people just have asthma alone. Any one of those. If you are dealing with this sort of problem and we prescribe you this is for mild case or over-the-top symptoms that are beyond your maintenance. I'm going to tell you that these are very similar to maintenance inhaler, but they go on sporadically. And that's okay, as long as you don't keep using them over and over and over again. Because if you are, then that's more than what we intended it to be. We just want you to use this very rarely. So if you keep running out of this, there is a problem with your maintenance inhaler, which is why I'm here today. And I'm talking to you about the ones that are prescribed. They have a direction that says, take this inhaler, 1 puff twice a day. Take this inhaler, 1 puff a day. And then take this inhaler, 2 puffs twice a day, or 1 puff twice a day. See, these are twice a day inhaler on a maintenance inhaler. This one is a twice a day on a maintenance inhaler. This one is a once a day on a maintenance inhaler. There are others. This one is a twice a day on a maintenance inhaler. When I say twice a day, I didn't ask you the next day to ask yourself, do I feel good? Oh, then I won't take this. There's no option on that. Now, if your doctor wrote an option, go to them and talk to them about it. But if they did and you're having issues all the time, maybe that option needs to be removed and you need to be using it how it was prescribed or changed to twice a day, because this is a twice a day medication. When we say, or you feel, okay, it's too strong for me, I'm doing so well, now I need to cut down. This is why you need to seek care about that, because something like this or something like this, we don't change the sequence or the fixed schedule or the prescribed schedule. We change the dose within the particular canisters. And what happens is people feel like, oh yeah, it's time to cut down. And they take what is a twice a day and they make it once a day, thinking they cut down the dose that way. That's not good, because how they work is they sequence each themselves and they escalate and they compound and they layer, right? And they add, kind of like when you put, and I like to use a example of when you apply a lotion to your hand or your face. The first one, you may not see the effect, but maybe few weeks, few months later, people start noticing you, oh wow, I like how your skin looks. That didn't happen with you applying it every so often, because it was not prescribed or it wasn't given with those directions. You would follow it exactly the same. There's plenty of other examples. If you were taking a Tylenol, you wouldn't just take one in the morning and then when the pain comes up in the evening, you're not going to take it, because now it's kind of wore off. The effects of these drugs do wear off and they compound better when you follow the schedule of that particular medication. So Yes, I am on live. I hope. Um, yeah, people. Okay, so now the COVID discussion begins. Most people that smoke never got COVID. I don't know. I met a lot of people who smoke that got COVID. So I will tell you, it's not a debate. You can just ask anybody. It's not a debate. I'm not going to talk about COVID as in the COVID pandemic. I'm going to tell you that COVID is now like a regular respiratory illness, just like everything else that we don't talk about too much, but exists, like flu, like influenza, parainfluenza, metapneumovirus, any kind of respiratory illness is now fair game, right? You would probably accept it better if I say that people who have phlegm attract any kind of bacteria. It's just basic knowledge. And any kind of bacteria will make your life a living hell because it exaggerates your situation with the phlegm and it clogs you up way more than you ever wanted it to clog you up. And it is for that reason that I will tell you that when you have asthma or when you have COPD, the way I label you is you at risk of things getting out of control way faster than the general population. And you at risk of spending more money, seeing urgent care, which they love, and seeing pulmonologists, which we love too, and then seeing your primary doctor and making the respiratory world and the medical world really lucrative because you have not caught on to the fact that these inhalers are meant to help you kind of cut back on your expenditure in the health system. And if you don't get that, I'm being very direct, it means you'll get more flares. And what do more flares do? They make you see more of us. And what does seeing more of us mean? Well, more co-pays and more uninterrupted hospitalizations because you just get them one after another, right? You never get a break from those hospitalizations. Your ER becomes your last name, your bronchitis, prednisone, antibiotic, and the abuse of antibiotic becomes crazy. So what I would say is I want you to know that it is very, very important that you understand that this puts you at risk of more medical issues, of which they can tag different names to it. They can tag it asthma flare-up if you have asthma, COPD flare-up, asthma bronchitis, upper respiratory tract infection, I blanked out, bronchiectasis, they all kind of wind in there and they fit in. And bronchiectasis actually happens after a long, long time of total abuse of your lungs. You just tear them up and they just become so destroyed. The lung has its own architecture, but as you get repeated infections and infections become permanent fixtures in your lungs behave a little bit more destroyed and they clog easier. You house a lot of phlegm, and phlegm shouldn't be in your lung. I don't care what illness you have, you really need to work on trying to get rid of the phlegm because it actually makes you more at risk to get more bacteria, because bacteria can share the space in your lung very easily. If you have one bacteria, you can have two. If you have two, you can have three. There's plenty of room. You can fill 10 different. They're not going to say occupied by staff right now, so I'm not going to get, let me not say COVID because that makes everybody upset. But you can get 3. And I've seen people where we test them and they have 3. And I've seen people where we test them and they have 1. And I've seen people who have already gotten rid of the bacteria and they still have a lot of phlegm and irritation. That irritation is what we are trying to talk about, how to keep your lungs calm and not over-flared and overexcited. And when that is the plan, we give you a maintenance plan when you're well or better than when you're in the hospital, in the ER. We give you something that can work very aggressively. And as a result, it works faster, but it's very high levels. To mitigate that, we tell you you need to be on an inhaler on a daily basis. And some of them are once a day and some of them are twice a day. So you need to go and sort out whether yours was prescribed once a day. You really should. If after we talk today, you don't feel like you got my message, what I'm asking you to do is a very simple, go check and see whether your inhaler was prescribed once a day or twice a day. Go check if you have a rescue inhaler or a maintenance inhaler. Go check if you have both. and that you've really differentiated your maintenance inhaler from your rescue inhaler, because they're very different. And what you should do also is find out whether your provider has also included you to be on a medication for your allergies. If so, are you applying that on top of your care? Do you need it? And are you consistent with that? Because things that deal with respiratory illness are chronic. And if you have allergies, maybe you know yours are seasonal and you're only going to apply in the fall time, then you do it in the fall. But some people have consistent irritation that requires yearly medication to help you block the allergen, because asthma, and sometimes when you have COPD, you attract kind of an allergic situation where you're in situations where when the allergies flare, your lungs also flare. So you would be taking something for the allergies. Maybe your doctor has also said you have reflux, and the reflux is irritating your lungs further. And they will add maybe something for reflux as well, because the acidity is probably intermingling with your lungs at some point, if they feel that's the case. We don't do that so often, but we do sometimes have people who have reflux and asthma, and it coexists and causes sort of like a synergistic problem, like things kind of like double up and they make this huge, not 2 + 2, more like 2 + 2 = 6 instead of 2 + 2 = 4. So I just want to let you know that most of these things we are doing because we want to protect your lungs from us giving you steroid, which is pills. Sometimes when you're in the office, or we may even give you a shot of steroids for those people who do that. Or we may even say, we're not going to give you a shot, but we're going to admit you and do an IV steroid, or, more aggressive steroid administration. Instead of once a day, sometimes 3 times a day, because we are just trying to take over your breathing pattern. And I also want to tell you, we're also trying to get rid of that phlegm and that irritation, and the congestion is dealt better with the steroids. So we are just going over these things in a basic way. Right now, I'm just going to go over some basic inhalers just so that we kind of review that as well. If you're having a hard time with your inhaler, you have a hard time with holding your breath for 10 seconds, then try 6, and then kind of hopefully you will build into where you can take the breath and hold it for a full 10 seconds. When you're counting, you're not doing 1, 2, 3, 4, 5 very fast. You want to slow it down. I don't want you to pass out when you're counting, but I really want you to count in your head or by counting like how I do it, so that you're sure you're taking the time to actually intake that inhaler so it works. When you don't do that, I'll show you that you will, if you don't shake it, first of all, you should shake it. These don't need shaking, just these type of inhalers, you do. And if you don't really understand which one shake, which one don't shake, just shake these type of inhalers, okay? That is what I tell you, because I want you to get into the habit of shaking them. That shake allows the medication to mix in, right? And then it also allows you to, the first time, or if it's your rescue inhaler like this, if it's been sitting out for a long time, you want to shake and press. But if it's your maintenance inhaler, you will shake it and inhale it after you've primed it the first time. That always, when I explain that, I always feel like people will get confused. So the shake is mandatory. All of these inhalers that look like this should be good shake to mix them up. Mixing is mandatory. Priming is when you let it out, like you test it and it comes out of your inhaler like this. You see, when you don't shake it, it doesn't come out the first time, but you shake it and then you see that air coming out. That means you're now primed. You have both, you shake and press. That is the first time out of the box. It needs to be shaked and pressed. After that, if it's your rescue, you're gonna do that again whenever you apply. You're gonna shake, prime it, because you probably didn't use it consistently. And after a while, it kind of loses that flow. So you wanna make sure it's flowing, that you're gonna get your medication. And then if it is your maintenance inhaler, you're gonna do it the first time when you open it. But if you're consistent, which is what you're supposed to do, you will do the spray into the air one time, and then you're gonna spray into your mouth ongoing until it finishes, because you're always using it. It never has time to lose the spray. However, if it's your maintenance, you use it once in a blue moon, you're going to have to shake and prime each time when you get started and you haven't used it in, let's say, even, I would say even 3 days. I would shake and spray it because you want to make sure that it's flowing. So it's kind of like a test dose. The prime is considered a test dose. I'm sorry, I got some calls coming in. But the shaking is waking up the dose, making sure that it's mixed and woken up. So I'm just trying to go through maybe 1 or 2 of maybe some of the inhalers. That way we kind of cover some of these basics. But I want to highlight that when we are dealing with the rescue inhalers, there's few of them out there. They could be different colors. These are rescues. This one is a rescue too. See, this is a rescue. This is a rescue. This is a rescue. This is a special kind of rescue. These will be seated sometimes a month, 2 months, and I'm happy because when your provider is happy is when you don't need your rescue, or you tell your doctor, I don't need to refill my rescue because I hardly ever use it. That means your lungs are really well controlled for the most part. However, if you have the other kinds, these ones, right, this one, and others, you know, this is a different type of a maintenance inhaler. We have this one as a maintenance inhaler. These are twice a day, right? And your doctor may have prescribed them different. That's for you to ask your doctor. I'm not here trying to be your doctor. I'm just trying to tell you that some of these are twice a day. And you need to pay attention to that twice a day. And then you need to pay attention. Did they say 1 puff or 2 puffs? These are usually twice a day, but they're 1 puff each, twice a day. The dose matters when we prescribe it within the dose. So we may put a low dose, but we're going to put it twice a day. We may put a high dose, but we're going to put it twice a day because these inhalers are twice a day inhalers. This one is 2 puffs twice a day or 1 puff twice a day. That is how it's prescribed as a maintenance inhaler, unless your doctor said something different. You've got to go back. That's the most important thing. Go back to your prescription. If you've lost it, I understand. This is why I stick on my patient. The ones who get confused, I put a little sticker to remind them that this one here, it says, please take one puff twice a day. 1 puff once a day. And I tell them to be consistent on that. Keep it next to your toothbrush because you brush your teeth at least once or twice, right? And if it's a once a day, it will work. In the morning, you'll remember you use it. And then if it's a twice a day, it will also work if you put it next to your toothbrush because you'll do it in the morning and then you'll do it at night. And what's even better is that you will rinse your mouth after. Some of these inhalers require you to rinse your mouth so that you do not get the thrush or the kind of like accumulation and irritation of the powder when it reaches your back of your throat. And sometimes some people can even say it's sore or hoarse, or they may even have like a white residue on their tongue because they're not doing the oral care after. It's not a side effect, really. It's really more like you didn't know better. Like you didn't know that you're supposed to rinse your mouth after your inhaler. And if you didn't know and you get confused, then rinse after all. That won't be a harmful thing to do. It's just when you don't do it, and for some people, they have a higher propensity to have hoarseness, thrush, what we call on top of your tongue, the white kind of discharge on your tongue. It's like fungal overgrowth from the powder that gets deposited in your lung. You also need to know that your tongue needs to sit, when you're taking inhalers in general, you want to make sure that your tongue is not in the way of that inhaler. Don't block it. Don't do this. It's going to spray your tongue. You need to make sure that the tongue is down. And your airway is coming like this into the back of the throat. You're helping this inhaler get into your tongue, into your lung, not on your tongue. But some people just literally spray really bad and everything deposited on your tongue and in your throat because they don't even give it a nice breath. They do something like this. That's not good, right? Because that powder or that mist is in the air and it will be in the air in your mouth, right? It's not supposed to be there. You're supposed to suck suck it in and get it to deposit in the lungs where the problem is. The problem is actually deep down in your lung, really, really deep down in those small little airways, way down in your lungs. So if you're not actually propelling your inhaler all the way down, you're actually gonna cause a lot of these side effects up here because most of your medication is getting deposited in your mouth, your throat, and in the back of your throat, rather than it being deposited down 90% to 10% up here and 90% down here. A lot of it gets deposited in your mouth. And some people say you need to swallow. It has nothing to do with swallowing. You take your inhaler, it is an inhaler, it's not a pill. You don't need to swallow anything. If you want to, you can, but you should really ask yourself, why are you swallowing? Did you swallow the inhaler or were you supposed to inhale the inhaler, right? You should be taking a deep breath, hold it to 10, that's the general plan, and then you're going to exhale. So I'm gonna show you that this is what is gonna apply to all of these inhalers, and we're gonna do these one after another. And if you have one that you want to request, you can type in. And I will give you that if I have it. I want to let you know that yes, you may think this is the solution. Yeah, could be, but that should be when these things don't work. So I just want to make sure also that I mentioned to you that if things don't work out, some of these you can put in a spacer like this. Do you all need a spacer? Well, for those people who have a hard time, challenging time with the arrangement of how to do this, and they feel like they can't catch the breath on time and they blow off the inhaler, maybe you should get a spacer, and anybody can get one. You don't need a script. You can go on Amazon and you can get one. I have some on my Amazon store. You could go and get one if you want, or you can go to your medical supply of choice and get it. You don't need to get it from me, but you do need to get a spacer if you can't coordinate this, or ask your doctor to switch you over to an inhaler that's easier for you to use. Sometimes my patients, I feel like they're much better on this. Sometimes they gotta be on this. The thing is, some of your rescue inhalers may come like this, so you might as well learn how to use your technique with or without the spacer, because the rescue inhaler will only be a rescue if you know how to use it. So I'm gonna go over this, and this is an albuterol. So I will shake it, I will prime it. You see how that didn't flow really well? It may be out actually. I think this one, no, it's not. So that was just why we do priming right there. And then you see, now it came out. So after that, we know it's working. You would put it in here, and then you would so you see, I'm gonna come closer. Shake it, prime it if it hasn't been used in a long time. If you feel it needs to be woken up, you feel like it needs to be tested whether it flows, you would do that. But you will always shake it before you use it. Put it right in here, very easy. You don't need to have a spacer. I'll show you without as well. And shake it, and then you're gonna So you will do one spray, and you will do count 3 to 4, but you're gonna do, this is not the same as when you do this without a spacer. You would prime it if it hasn't been used in a long time, but you will always shake it before use, right? So now, this is a scenario where you did it without the spacer. If that's too, how do you know? Go sit next to the mirror, and you can go like this. If you see that, You need to have a spacer maybe, or you need to be perfected. And I do both. I will teach you how to get that perfected, but you either joining into one of these lives and watching me do it and then realize, oh my God, I made a mistake, accept it, and then we can go on from there. Because what you want, that mist is actually your medication. You don't want that to exit. You want that to sit inside your lung. So watch me do this where it sits in my lung and it disappears and you won't see it. Shake it. Why do I blow out? I blow out so that your lungs can actually be empty to receive the next breath, which is going to be with medication. And you can pull it into your lung. Make sure your tongue is down. Down. So that when you take a deep breath in, your tongue doesn't get in the way and block the exit of the medication, right? So shake it. Exhale. And then as you press, let me do it this way. As you press, you also inhale at the same time. You see? Nothing came out, right? That is versus this. You see that? Yeah. One has an administration of medication and the other one doesn't. And unless your doctor is going to spend some time with you and check it and actually look at your breath, we don't know. And you're going to say, yeah, I'm using it. And that use really has a few degrees of falling apart. And if you don't know it, then you're going to say, well, it's not working. And somebody says, well, that means your situation is very severe. We need to add more. We add more and we add more. And add combination, higher dose. And it's not going to matter, because if you take the maximal dose of your maintenance inhaler, let's say it was the highest possible prescribed inhaler, and you do this to it, it won't matter. So they go up, up, up. And then all of a sudden they say, you know what? We got to go to injection because you just failed the inhalers, right? And this is why I'm here. I want to let you know that if you listen this far, it means you understand that you want to know why is it that your lungs are not working. The inhaler is not working for many, many, many reasons. I can think of 10 things that you can go wrong on. But what I really would rather we do is that I tell you, perfect your inhaler technique. Go find a video of choice on my profile. I'm on TikTok. I'm actually on YouTube more now, but I want to let you know that I have a bigger library of videos on TikTok. But you can also go to your pharmaceutical company or wherever you got your inhaler, look up what their technique is and learn. And once you've learned the technique, then you can figure out if I'm not doing well, then maybe I need a spacer. You can go to your doctor and get a prescription for a spacer, or you can go right on Amazon, get your spacer. Or you can go and get one at your medical supply of choice. But this is something you can sort out. This is the same prescription, whether it's on here or not, but it could be a big problem when you have the same prescription, but you're not getting it because you didn't know that your medication is being expelled out of your lungs and you're not actually getting it. So once you have that sorted out, I want you to pay attention to the fact that, let's say you have a good technique now. We worked with you and you worked with my videos, or you worked with your doctor, or whoever is doing the teaching for you. Good thing. Now you got it, and then now you don't have the schedule right. That's going to be pointless. One inhaler could be a rescue inhaler. That's great. If you're using it once a month, once a year, you're on and you're fine, great. You are doing good. That's great. You and your doctors are perfect. But let's say you're only on a rescue inhaler, but you're using it every day. That means there's a problem. That is not meant for every day. It's meant for rare occasion, over the top symptoms, and we need something extra because your maintenance inhalers are not meant for extra. So then you're going to say, well, what's wrong? It could be that your maintenance inhaler isn't dosed in the schedule you're supposed to be. So you go back to your box of your inhaler and you threw it away. You don't remember. Go to your pharmacist and ask them, do you remember what my doctor wrote for me to use? Because they may have written, use this 1 puff a day or 2 puff a day, one or the other, twice a day. And then you were doing it some other schedule that didn't make sense and it wasn't working. You perfect your technique, then you perfect your schedule, which was prescribed, Then you and your doctor are on the same page, and you can talk about whether you need to go up or down, because sometimes it's not that you need to go up, you just need to perfect the technique. And sometimes, even though you perfected your technique, you need some more time on that dose, as long as you're safe, to make sure that you got into the best compounding effect, because they do take like a week or two to settle into their full benefit. So one puff is your first dose, you get maybe, let's say 10%, then 20, the next day you go into 30 in the morning, and then 40 in the evening, and then 50, then 60, then 70, then 80, then 90, then 100. And then the next day it's going to be already at 100. And if you continue at twice a day, you're going to maintain your 100 effect. But let's say you didn't know, you perfected your skills now, and you're like, okay, why am I not getting better? It could be that you're using something like this on a as needed basis, and that's not a good idea. So now I do need you to go back and check your prescription and find out what your doctor said. And if it's not controlled, don't wait until you get a flare. It's so hard to get somebody through a flare. I'd rather we fix the technique and your sequence way before you get into a flare, because when you get into a flare, we've got to use bigger things. Yes, they're the same exact thing, but in higher, more potent doses to kind of get into your lungs faster, and the rest of your system gets it too. Your eyes gets it more, your bones, your back, your throat, your everywhere gets it more too. So I want you to remember that you do need to make sure that you keep your schedule the way it's supposed to be. So I just want you to know that these are simple things you can do at home. You probably already have the right script, but you're probably not optimizing it. Sometimes we do have a lot of things, we're just not using it to the fullest benefit. And I'm only here to tell you, I don't understand that question, but you can ask it again. If it's related to asthma, I'm more than happy to answer back or respond, should I say. I just want to let you guys know that you can perfect a lot of things at home. There's a lot of things that you can do right off the bat. You can easily quit, right? Cigarettes and vapes, yes, I know it's not easy, but I'm saying that should be something you attempt to do, not just optimizing your technique and then optimizing your schedule and then optimizing your consistency. It's also, please make sure that you don't do things that are working against you, which is smoking, vaping, yes, marijuana included, everything else, air only into your lungs. Healthy air, if you lived in a place where the smog is so high or whatever, the air is thick with pollution, then maybe you need to be on an allergy pill on top of that. Maybe you live in a carpeted home. You need to try to make sure that the next home you don't have it carpeted. If you have a chance to remove the carpet, do that. If you have a mattress, inside your mattress, it could be things that are making your asthma worse. And when you lay down, you're actually intaking the toxicity of those bed mites and dust and everything. So your home environment needs to be healthy and clean and dust-free if you can, right? Then the other thing is, if you have post-nasal drip, take care of that post-nasal drip. It's going to make you cough and then make you congested and kind of keep repeated infection. What else can it be? Reflux, take care of the reflux. If you have reflux, try to eat properly. Try to take care of the weight. If you have weight, these things kind of work against your lungs. They're added things that you need to know. If you tend to get a lot of infection, it could be because you harbor a lot of phlegm. Get rid of the phlegm. Try to use something to help you cough up that phlegm. Try to use your medication and try to maintain dry lungs. That's what the inhaled steroids do. If you're not on one, maybe check with your doctor why you're not. Yes, inhaled steroids is just going to be targeted to your lungs. It's not the same as when we give you pill and IV. We do that when you're sick or in danger or hospitalized. What else can it be? If you have pets, we love the pets, but just know that maybe you shouldn't sleep with them on the bed. Maybe they shouldn't be in your room at night. Maybe you should find out when your current pets are no longer with you, maybe what kind of pet would be safer for you, if there is such a thing or an option. I love your pets too. I just want to make sure you understand that some of them are really causing you to be sick, and you need to know that. Cats especially. I'm not being rude or mean. I love all animals. I don't have any pets, but I love all animals. I just want to make sure you understand when you have a pet that is doing those things to you. Maybe get an air purifier. So many things you can do. You can look up the topic of asthma, learn a little bit every single day, learn how to advocate for yourself. So there's so much that you can do at home. anytime with your providers, though, I think it's a smart idea if you're struggling with your disease that you first accept that you have a problem. Ask your provider for an x-ray, because sometimes what we treat as asthma COPD is not. It could be asthma COPD plus pneumonia, so you need to take care of all. It could be asthma COPD plus reflux, we're going to take care of all. Asthma COPD allergies, take care of all. It could even be congestive heart failure, God forbid, something totally different. We're going to take care of the asthma, if it's there, the COPD, and then the congestion, something totally different. It could be asthma, COPD, and anxiety. You got to take care of all. Post-nasal drip, take care of all. I'm just being very real here. The irritability of your lungs is going to depend on how many things are actually causing you to flare. We call them triggers, exacerbating factors, whatever you want. Things that make your situation way more obvious and disturbing, interruptive, and completely just unfair, right? You can make it like level the ground with the asthma that's there every day. Learn how to take care of it and learn how to optimize your technique. If you have never been diagnosed and they're working you up, in the beginning they put you on inhalers, then they will do a test. If they do a breathing test and you don't have asthma, it could be you took your inhalers recently. Talk to your doctors, let them know you took it before you took the test. They should be able to figure you out, and they should try to see if they can safely take off the inhaler and test you off of inhalers. Maybe you treated your inhaler before your last test. When we don't know if the inhaler is working, we do spirometry, we do breathing tests to check whether your inhaler is working at that dose. And remember, that's with us confirming the dose we wrote down. That doesn't mean it's the dose you take, because if you take your inhaler and you blow it out, you may be taking 0 prescribed inhaler even though you have it filled, right? Because it's 0. You took it, inhale, and you exhaled all of it. So this is a pretty long live, and everybody gets a chance to explore what I'm saying, understand what I'm saying, and just realize that it is simple to understand what you need to do. It's not simple to apply, and not simple for you to understand that you could be possibly doing the wrong thing for 20, 30 years. You could even be in the medical field and still do it wrong. Your doctor may not know how to use these inhalers. Look them up, advocate for yourself. And definitely, I would love to see you again in my next live. And if you have a video comment, you can post it on this video when I post it, or in the future videos. I wish you all the best, and please take care. Bye. It's Dr. Mkono.